Are you ready for me to start?
Yes.
Okay, good. You can hear me okay. All right, good. Well, welcome everyone, and happy to be the first speaker in this new program, which we hope people will find helpful. So this topic is one that we picked because it's a really common issue that people who have rheumatoid arthritis, and this also applies to other inflammatory types of arthritis, whether it be psoriatic arthritis, ankylosing spondylitis, is that it's very, very common that when someone has the arthritis, they also have another condition, whether it's another condition that's part of the overall picture of the arthritis, which there are many of those, which I'll show you, or they have a different condition that's not necessarily part of the arthritis condition, but that complicates the management. So I would say it's probably only one person out of 10 or one out of eight who actually doesn't have other conditions. So this applies to the great majority of people who have inflammatory arthritis. So we need to consider that when we're picking treatments. So that's the focus here and maybe be the focus of some of your questions at the end. This is just whether we have any disclosures relevant to this topic, and I don't. Okay, so the outline of what we'll be talking about. So what are the types of conditions that can complicate rheumatoid arthritis? So what are ones that can be part of the overall arthritis picture? What are ones that are not part of it but can complicate management? And how does treatment change when these conditions are present? So this is a long list, and I'm going to go through them one at a time, but just to show you the extent of the kind of problems that you need to think about. So this is, let's say somebody has rheumatoid arthritis, since that's the most common type of inflammatory arthritis. We'll talk mainly about that, but the principles apply to the other types of inflammatory arthritis. So someone with rheumatoid arthritis, certainly most common symptom is the joints. The joints are stiff, they're swollen, but there are a lot of other things that also can go on that are directly related to the arthritis condition, like fatigue, low-grade fever, lung problems, increased risk of coronary disease, cardiovascular risk from lack of mobility, increased infection risk, increased malignancy risk, particularly things like lymphoma, lung cancer, osteoporosis related to not moving around, dry eyes and mouth, depression. So we'll go into them one at a time, but just I wanted to give you sort of the feeling that I think those of you who have the condition know already that it's pretty likely that you have something else than just the joint pain. So how do we deal with those problems? So these are ones, again, that are part of the arthritis, but other than the joint. So what about fatigue and low-grade fever? Fortunately, most of the time, this gets better when you use the treatments for the arthritis. So if somebody gets methotrexate or Enbrel or one of these medications, adalimumab, Enbrel is etanercept, when people get these medications, it often generally will help the fatigue and low-grade fever as well. Lung problems such as scarring, that's a certain percentage of people with inflammatory arthritis, rheumatoid, will get lung scarring, and the rheumatoid arthritis medications tend to help there as well. The increased risk of coronary disease also seems to be helped. If you can, it seems that the inflammation is the cause of the risk. So if you're able to get at the inflammation and quiet down the joints, you're generally also helping coronary risk, and that's been shown in several studies. The same issue with lack of mobility. If you treat the arthritis, get the person better, get them up and moving around, that helps to reduce cardiovascular risk from lack of exercise. Increased infection risk. We know that untreated rheumatoid arthritis patients have more infections than other people. And what do? Well, we have to watch people more closely, more surveillance, and vaccination. So we do, I'll mention that later, some of the details, but we do like to make sure that our patients with inflammatory arthritis are up to date on all the relevant vaccinations. Increased malignancy, particularly lymphoma, somewhat less lung lung carcinoma, rarely colon, but particular lymphoma we know is increased in people who have inflammatory arthritis. And again, it's surveillance, being aware that this is an increased risk of somebody develop lymph node enlargement, that kind of thing. And of course, if they get any malignant condition, to manage it and to consider how the arthritis medications might change in the setting of management of malignancy. Osteoporosis, that's a big one. It's a common risk in general, but arthritis patients often don't get around. They don't get the weight-bearing exercise that they need. So how do we help that? Rheumatoid arthritis medications can improve mobility, monitor people with bone density called DEXA machine to see how dense their bones are, and if their density is low, to treat it. Dry eyes and mouth, there's specific dry eye management, drops, medication for the dry mouth. There's ways to increase salivary flow so that we have treatments beyond just the medications that would be used for the arthritis. And depression, common in the population anyway, but it's more common in people that have a chronic inflammatory illness. So you want to watch people for development of depression, and it could be treated just like any other depression with medications, cognitive behavioral therapy, education, and of course control of the arthritis, which often helps the depression as well, because part of the depression is what we call reactive, that you have the illness and it impairs, you're able to do some of the things that you want to do, and that can affect your mood. So just getting the arthritis better often will help that as well. Okay, so what are some conditions that are not part of the arthritis, but are common and can complicate management? You could have a history of inflammation in the bowel called diverticulitis, history of multiple sclerosis, hypertension, diabetes, certainly very common, heart failure, prior lymphoma, or other malignancy. These are all things that come up all the time when we're seeing people who now have rheumatoid arthritis. So what do we do about it? So if you have diverticulitis, we have some of our medicines that don't seem to be good for those patients. I'll show you later when we talk about the specifics, but there's some drugs that are called IL-6 blockers and some that are called JAK inhibitors. I'll show you them. JAK inhibitors are oral, IL-6 are either self-injection or IV, but those are medications that we're told to avoid in somebody with diverticulitis. History with multiple sclerosis, we tend to be cautious with the use of TNF blockers like etanercept, adalimumab. Hypertension, we try to be careful with anti-inflammatory drugs like Advil, ibuprofen, or naproxen, Aleve, and prednisone, oral steroid. All those medications have the potential for raising blood pressure. People with diabetes, you want to be particularly careful with prednisone, and also to be aware that people with diabetes are more subject to infection. So you want to be even more careful about infection than with the average arthritis patient. Patients with severe heart failure, we need caution with TNF blockers like etanercept and adalimumab. And again, I'll show you a little bit more about these individual drugs as we go. History of prior lymphoma, you need to consider in medication choice. There's one drug called rituximab, which I'll show you, which may be a better choice than somebody with prior lymphoma. History of other medication, other malignancy, may also want to consider that in medication choice down the road. All right, so how do we handle the management of rheumatoid arthritis, considering that some people have complications of the rheumatoid arthritis itself, and some will have separate coexisting problems. Some people will have both. So one point that's good to sort of have in the back of your mind, if you're either already on a drug like a biologic drug or methotrexate, is the general concept you want to have this. This is very important if you're about to start, and also important if you're already on it for easing your mind, is to know that, first of all, pain, stiffness, joint damage, disability are directly linked to disease activity. So it's really valuable to a person to get that disease activity under control. Infection is more closely tied to disease activity than to the medication. People are always very worried about the medications increasing their infection risk, and that's a genuine concern. But unfortunately, it turns out that just having active inflammation in your system is a risk for infection. So you need to know that. And medications like methotrexate and biologic meds actually have a relatively small infection risk, particularly in people who don't have things like diabetes. Um, and we also know that if their activity remains high, let's say the first medication you give doesn't work, the person remains at high disease activity and high infection risk until you get the right medication. Prednisone also is particularly known to increase infection risk, so we use it because it works so spectacularly, but we try to get the dose down, and if we can get rid of it in a patient with rheumatoid arthritis, we do. And then the heading of this slide is always something to keep in the back of your mind, is that rheumatoid arthritis is more dangerous than its treatment. I think that's really, I think a lot of my patients have felt that getting that concept helps them to deal with things, because the medications can be a little scary when you first start and you read all the side effects, and they can increase infection risk, for example. But it turns out that the disease itself is more dangerous than the treatment. So, for example, a nice study in Sweden looked at whether people who are on one particular drug, they were looking at etanercept, uh, did patients have more lymphoma if they were on the drug or not on the drug, if they had the same level of disease activity. And it turned out it was the same, that people with more severe disease activity do have more lymphoma than the general population, or than rheumatoid arthritis that's totally well controlled. But it wasn't the medicine. When the medicine first came out, there was concerns because some patients did get lymphoma, but it turns out it was the more severe patients that were being given this kind of drug because their arthritis was out of control. And those are the people who are more likely to get lymphoma. So it just eases your mind a little bit about the medication. The same thing about cardiovascular risk. We know that rheumatoid arthritis itself is associated with cardiac risk, particularly related to disease activity and also to not moving. And there is some data that methotrexate and TNF inhibitors like etanercept that control disease activity have been shown to reduce the risk. So, and also the last bullet, most of the issues that worry patients and doctors most are 1 in 1,000 rare events like cancer, lymphoma, tuberculosis, unusual infections. Things can happen in people on our medications, but it turns out that it's less than if they weren't treated. And the bad events are actually pretty rare, especially in somebody who's fortunate enough not to be predisposed to infection by other things like diabetes. So then thinking about the overall management of rheumatoid arthritis, when I talk to people, I always try to start with the least invasive first. So rest, balance with activity or physical therapy, splinting when appropriate, local injection with steroid can be helpful, topical treatments like topical diclofenac or lidocaine. There's local treatments that can help, medications of all types, painkillers, standard disease modifying drugs like methotrexate, and then biologic drugs. And this kind of program, education, peer, professional support, being able to talk to other people about it, talking to people like our social workers, educating yourself about the condition. I think in general that education for people with inflammatory arthritis eases their mind a lot, because they just gradually see that what they're doing is helping them, and that whatever risk they're taking is actually well supported by the benefits that come out of treatment. So when we're discussing the medication side of this, what are the choices? What are the types of medications that we use? We use nonsteroidal anti-inflammatory drugs, although we use them less than we used to. That's like the over-the-counter ibuprofen or naproxen. We use them less because we know that they have side effects, like there's an increased cardiac risk with them. They can raise the blood pressure. They can increase kidney problems. So we're using them less. Fortunately, we can use them less because the other medications, which I'll get down to in a second, those medications are so successful that often we can get people off drugs like nonsteroidal anti-inflammatories. We do use painkillers, analgesics like acetaminophen, Tylenol. Steroids like prednisone definitely can get us out of difficult situations if somebody's really flaring up. That's the most quickly effective and dramatically effective medication, but it's got so many side effects that we want to get people off. And then you have disease-modifying antiemetic drugs. That means ones that can actually stop damage to the joint, like methotrexate. Then we have biologics. And again, I'll show you a little bit of what the spectrum of these kind of medications is. And the biologic medications or combinations. Many patients will be on, let's say, methotrexate and a biologic like etanercept or adalimumab. So let's start from the beginning. So anti-inflammatory drugs. So I'm going to focus for this particular talk on what are the side effects related particularly to people who have underlying issues. So we would not particularly want to give anti-inflammatory drugs like these that you see here, Motrin, naproxen, people with high blood pressure, with heart disease, with ankle swelling, ulcer history, because they can cause ulcer. Those are things that we'd be wanting to keep in mind if we're giving somebody these anti-inflammatory drugs. Then we have corticosteroids. So the usual statement in rheumatology is that rheumatologists have a love-hate relationship with steroids, and most of our patients who take them end up with the same thing. They love them because these medications are incredibly effective. They work quickly. They can dramatically decrease swelling, pain, stiffness, fatigue. Very nice. But we have additional concerns because they can raise blood sugar. So diabetics, they're a problem. They increase infection risk. So patients who are prone to infection, it's a problem. They can cause weight gain. Patients who are concerned about their weight, it's an issue. Patients with ulcers, they can thin the bones, steroids. So patients with osteoporosis, it's a problem. They can raise blood pressure. So hypertension is a problem. They can cause ankle swelling. So there's a lot of underlying issues that would make us be a little extra cautious with steroids. As much as some of you might know, they got the Nobel Prize in the 1950s for prednisone, for steroids, and they showed people getting out of wheelchairs and that kind of thing. But steroids don't really stop the damage, but they dramatically stop the inflammation. So they have a place, but we need to be careful. Plaquenil, hydroxychloroquine, is a mild drug for rheumatoid arthritis, but there are some patients that get benefit, either occasional patients where we can use hydroxychloroquine alone, and then a number of patients who are on hydroxychloroquine in combination with other drugs. We know that in the long run, usually nothing happens for at least 5 years, but later on, people can get these pigment deposits in the back of the eye that could affect your visual field. So you have to be checked by the ophthalmologist every year. So if someone had diabetes as a background condition, we'd have some concerns about that because it could be harder for the ophthalmologist to follow you. So eye conditions with hydroxychloroquine is something we keep in mind. Then we have standard disease-modifying drugs. These are oral medications, been around for a long time. They do have a risk for liver involvement, and they can increase infections. So people who have prior liver disease or frequent infections are an issue. That includes drugs like methotrexate, leflunomide. Those are oral medications that are commonly used. How about biologic therapy? So nowadays we use a lot of biologic therapy because it turns out that the safety is good. We didn't know. They first came out about 1998, 99, but now we've had 25 years of experience with these medications, and the safety turns out to be very nice, and the effectiveness remains excellent. And especially now it's great because we have multiple of these biologics. So if one doesn't work, you can go to another one, and they have different mechanisms of action. So of course, you don't need to learn all of these, but it's the purpose of this kind of discussion is just to put in the back of your mind that we do have a lot of different mechanisms. So if one type doesn't work, you have an opportunity to try another. I remember when I first was doing rheumatology, we didn't have any of these biologic drugs. And when this one was the first one that was available, Enbrel, etanercept, I had a list of about 40 patients who were waiting for it because they were not doing well and everything that we had wasn't working. And many of them, this was the answer, and a number of them are still on it now. So what would be our concern? This is one group of these biologics called TNF blocking agents. That's adalimumab, etanercept, infliximab. There's two others I'll show you in a second. But these were the first ones out, and there's a lot of them available. But there's some evidence that these drugs might make multiple sclerosis worse, so you don't want to give it to somebody who's got it. Severe congestive heart failure might worsen, and they can increase infection risk. Like all of these drugs can increase infection risk. And these are just some of the others that are available, golimumab, sotalizumab, and there's all different ways to give them. Some of them are by self-injection, some are by IV. For the TNFs, there's no orals. It's all self-injection or by infusion by the nurse. All right, what about another mechanism? There's one drug we have that's it blocks activation of T cells called abatacept, and that can increase infection risk, but it's another opportunity. So if someone took a TNF drug, it didn't work, abatacept is an option for them. Then we have, I mentioned these earlier because of the diverticulitis association, that tocilizumab is an IL-6 blocker that can worsen diverticulitis, so we don't give it to people that have that history or people with frequent infections, but it can be given both as an intravenous or as a self-injection. So it's got some good options to be able to, some people for insurance reasons or personal reasons have a preference for whether they would prefer getting the medication intravenous or self-injection. And this is the kind of drug that's nice because you can get it either way. That's not true of all of them. Now, what about rituximab? That blocks B cells. These are immune cells. T cells and B cells are part of your immune system. And as you know, your immune system is overactive in the setting of rheumatoid arthritis. So the idea is to bring the immune system activity down, but not too far down. Brought down, but still where you have enough to fight infection. And if we can hit that sweet spot, which we can often do with these medications, the person doesn't necessarily get infections, but is able to stop their inflammation. So in rituximab, again, like all of them, we're concerned that people have frequent infections. With COVID, there's evidence that B cells are very involved in forming the antibodies that you make when you get a vaccine. And they did demonstrate that people on rituximab didn't get the same antibody response to the COVID vaccine as other people did. So that's always been a concern. Maybe there was a little less of rituximab given for a while related to the COVID pandemic because we knew that this was going to be a drug that would be problematic as far as responding to the vaccine. Okay, then we have an oral option. There's been some issues, although these are pretty strong medications, and a lot of patients like the idea that we have an oral option. Tofacitinib, upadacitinib, some of these you may have seen on television, baricitinib. So these are oral drugs that are JAK inhibitors, and they block a pathway that goes down and blocks multiple inflammatory proteins. We have concerns with infections like all of them. Diverticulitis is also an issue for them. And then there was a recent study that suggested in older patients with cardiac risk, that's the patients in the 60 and over group, that it might increase the cardiac and clotting risk that those patients have. So that's made us hesitate in the older population. There was some question about whether there's an increased malignancy risk that's still being debated. But that slowed down the prescription rate for these drugs, but they were still using a lot of them, particularly in younger people, where the studies did not show any increased risk. Okay, vaccination. This is a good time to talk about it. As many of you may know, we're being hit in this country now with a triple threat of flu, RSV, and COVID. All of them are out in the population now. So it's a good time to think about vaccination. So we try with everybody who's on these medicines. I mean, I think it's everybody who's at the appropriate age for any particular vaccine. But in general, people who are on these medications that can affect infection, we try to make sure that everybody gets these. So flu shot every year. There's one called Prevnar 20, which we try everybody to get once before age 65, and then they'll get it again at some point after 65. There's one called TDAP, tetanus, diphtheria, whooping cough, that the P is pertussis, whooping cough. And that's supposed to be every 10 years. As you might know, whooping cough is back. So we do try to encourage people to get this TDAP vaccine. Shingles vaccine, it's 2 shots. As of now, it's 2 shots for a lifetime, and that's recommended. Shingles is more common in people who get these biologic medications, and COVID vaccine. So we recommend that that also be gotten by people on these medications. And in general, the COVID vaccine has worked in our patients, even on the medication. The only hesitation is the rituximab that I mentioned. All right, what about screening tests that we use before taking medications that can cause immunosuppression? So if, let's say, you're about to start methotrexate, which is usually the drug that we start first, I say about 40% of people with rheumatoid arthritis, that'll be all they need to do. They'll go on methotrexate and they'll do really well. So what do we do as baseline? So just so you know why you're being put through things. So we need blood counts, are you anemic, white blood cell count, kidney and liver blood tests. We need to know those things in case the medication affects anything. You need to test for somebody being exposed to tuberculosis, either one of those TB skin tests, or we have a blood test called quantiferon that looks for exposure to tuberculosis. We would get a hepatitis profile to see if the person had been exposed to hepatitis B or hepatitis C. That would be important for us to know, especially if it turned out that there was any activity. If someone has a positive antibody, then we check, called a viral load, to see if there's actually any active virus still going on in the system. Certainly, if that's true, they'd have to be treated before we can give them any of these medications. Chest X-ray, because some medications can cause like methotrexate can occasionally cause an allergic kind of reaction that could cause some changes on the chest X-ray. So having a baseline is important. And also it's a way to look for infections. You want to know if somebody has any abnormalities beforehand. Antibody levels can be done. Antibody levels could be a few things. It could be the rheumatoid kind of test, like rheumatoid factor, CCP antibody. In patients who get put on rituximab, which decreases your antibodies, we often will check their what's called gamma globulins. It's the antibodies in your body that are involved in fighting infection, and we can check their levels so that later on we can check again and see how low they are. Sometimes we might hold off a dose if the levels are very low. Bone density study is important because, as discussed before, people with arthritis have a higher risk of osteoporosis. They're often not as active as other people. If they go on prednisone, we know that prednisone increases thinning of the bones. So we need a baseline bone density study. ANA, because occasionally some drugs like the TNF drugs, like etanercept, adalimumab, can cause an allergic type reaction where you develop this ANA. ANA is a marker of extra immune activation in the system. So we often get that as a baseline so we have it available in case someone has anything unusual developing, we can test it and see if it's a new finding. So how does a rheumatologist follow a patient on long-term treatment for rheumatoid for additional medical issues? So in an ongoing way, what do we need to do? So labs, for example, someone on methotrexate needs periodic liver testing because the medication can affect the liver. Most people, it doesn't have any major effect on the liver, but we want to know. There are some people we need to stop because of liver function changes. Routine malignancy screening. I think that's important since we know that the arthritis itself increases malignancy risk. We encourage people to do the things that everybody is told to do, but don't always do. Like getting colonoscopy when you're told that it's appropriate for you, mammography, the standard screenings for women, pap smears, getting the type of standard malignancy screening that's recommended. Monitoring for cardiac or respiratory issues, the disease itself could involve the lung or the heart, or the medication could theoretically cause an allergic reaction in the lung. So we need to follow monitoring for depression, as we discussed, that since that can be treated often, as mentioned before, the depression gets better when the disease gets better, but it can also be a problem in itself and should be managed as a problem in itself. And then working with other specialists. So if someone has any kind of malignancy, we want to work with the oncologist. If they need to give a medication, we need to find out whether that replaces our medicine or can be given with our medicine. Everybody's a little different there. So we need to work together with other specialists to do the right thing. Okay, and I wanted to give you some online review references so that you can find information in non-medicalese language. This is a nice reference. Um, I think you'll be getting these slides, but it's something you could write down, is that medlineplus.gov. That's from the National Institutes of Health. And you can type in basically any disease or any medication, and they have written summaries there that are written for patients, not for doctors. And they're very nice. They're reviewed, and I found them to be very reasonable and helpful. A lot of patients will look there. It certainly can help you find the right questions to ask the doctor, just get you a better understanding of the condition and the treatment. On our website for the hospital, hss.edu, we have lots of articles up there. We have a lot of summaries of programs like this. As you may know, this is new program that we have now that's going to have the Spanish subtitles, but we've had programs going on for years for long-term rheumatoid arthritis patients, patients with new onset rheumatoid arthritis, and we've been putting lecture summaries up on the website for a long time, and also things going up on YouTube. The Arthritis Foundation, arthritis.org, has a lot of resources for patients. That's a nice place to get information. And the same is true for the American College of Rheumatology, rheumatology.org. Lots of patient information there that can be very helpful. Okay. All right, I think that covers what I wanted to go through. There's always a lot more to say, but I think what we'll do is, why don't we leave plenty of time for questions, and I'll let Nabila